Thank you for coming. We're just waiting a few more minutes before we get started. Hi, Shahid. Would you mind unmuting yourself just to check that everything's working?
Can you hear me?
Yeah, can we just wait a couple more minutes
Yep.
people to gather? And
Yep.
in the meantime, I just want to remind everyone that this is actually the second of a two-part series.
Yep.
If you look at the description, you should be able to find a link to Shahid's event yesterday and give it a listen. There's a recording available. And in this event, you can ask questions in two ways. You can either raise your hand at the end of this event, ask a question, or you can use slido.com to submit a written question. So to submit a written question, please go to the website slido.com and use the code R0903. That's R0903 on slido.com. And if you are a bit confused about the code or anything, the instructions for how to use Slido are in the description of this event. I'd also invite you to please follow researcher highlights for events like this, which don't necessarily fit in any one category on our website. There's some really exciting things going on all the time, so please make sure you follow. And yeah, I think that we are about ready to get started. What do you think, Shahid?
Yeah, just give me 2 seconds. I'm just writing a quick note, and I'll be with you just now.
Yeah, just to give people a little more information to be able to view the slides in the presentation that you can see on top. Just click the arrows, and it will take you forward and backwards, so you can see old slides as well as slides that are coming up. Shahid will give us some cues onto which slide he's on. And again, please make sure to submit any questions you have on slido.com during the event, or you can just raise your hand at the end of this event to ask a question directly. How are you doing, Shahid?
Okay. Yep, that's fine. Okay. So I'm ready to start then. So I'll crack on then. Is that okay? Yeah.
Yeah,
Okay.
I think you can get going.
Okay. Thank you very much. So thank you once again for the researcher app team allowing this sort of collaborative effort in relating to World Kidney Day, or in support of World Kidney Day, and a collaborative effort between the researcher app team and the Renal Patient Support Group, or the RPSG. And today, I'm going to talk a little bit that follows on from the presentation I gave yesterday on the 8th of March, which related to some aspects around something referring to nephrotoxic nephritis. Today, I'm going to talk a bit more about the science behind nephrotoxicity and the importance of reduced immunosuppression in pediatric transplant patients. But suffice to say that the presentation I'm giving today does have a little bit of a remit around the adult nephrology population, those going through kidney kidney abnormalities in between pediatric between the pediatric population and the adult population. So this is an overview on the science behind nephrotoxicity. So this is slide 1. I'm now going on to slide 2, and I'm going to give you a bit of introduction. In relating to this topic as a general theme, is that biomedical scientists, immunologists, and clinical scientists tend to collaborate best when there is a consensus in investigation of renal transplantation. Looking at renal transplantation amongst pediatric patients, but also, of course, those in the adult population in the adult population, and those who require sort of transplantation following diagnosis of going through renal insufficiency for whatever the reason might be. Now, such collaborations are also envisaged best when there is a determination in the development of ensuring safe efficacy of immunosuppression therapy with reduced side effects, including nephrotoxicity being one of the main things, and especially more so post-transplantation. Now, ironically, nephrotoxicity can occur obviously as a result, for example, where individuals might be diagnosed with something that's referred to as acute kidney injury, or AKI, which might lead them into having which might lead them into having a renal insufficiency. But as in line with this, what it also means is that even when they're on a form of, for example, kidney replacement therapy or renal replacement therapy, in that time, nephrotoxicity might be less likely to occur to some extent, but that's not to say that it can't happen at all. It can still happen. Now, post-transplantation is even more of a risk, because many patients, especially in the pediatric population, as well as those in the adult population, and going through this particular area, in particular issues relating to where nephrotoxicity can occur, the physiology, especially around the kidneys, can have susceptibility and vulnerability, and especially where patients in both populations, generally speaking, are would have to take or be prescribed certain medications that can also prompt issues around the kidney physiology. Now, to identify best possible transplantation and match for pediatric sufferers, and allowing prolonged renal function, or serology laboratories focus on a few main things, and that is cross-matching, which is also cross-matching, and tissue typing, which is generally the consensus and consensus that relates to cross-matching and tissue typing. Tie into where clinical scientists have a remit to support clinical practice to ensure patients have the appropriate transplantation organ, when it comes to transplantation and organ transplantation. Ensuring that they have the best possible cross match alongside with their blood group, and also different paneling techniques are also organized in part of the serological workup of those patients, both in pediatrics and in adults who might require transplantation. Now, the importance investigation for possible match include lymphocytotoxic tests and mixed lymphocytotoxic culture tests, and both are forms of tissue typing. Now, a clone match can't really be established or identified unless a pediatric recipient is a twin, or what's referred to as a complete human leukocyte antigen compatibility, and referred to as a full house cross match. So HLA, the human leukocyte antigen, along with the aligned with the MHC, which is the major histocompatibility complex. But generally speaking, when serologically speaking, the tests and investigations are a kind of um, best matched. Basically, clinical scientists would refer this to as a full house, but a full house, generally speaking, in a full house in its entirety would not occur unless unless it's a twin donating an organ from to another twin or a sibling in this regard. However, close to this is those who are live cadaveric, live donors, and also potentially cadaveric, where apart from blood, there's an age matching aspect that comes into this, and then also in relating to again the HLA and MHC, where basically the immunological components are much closer. Thus, actually, when patients are required to have post-transplant anti-rejection therapy, for example, there should be less probability of having nephrotoxic side effects. So, in this regard, also, where twin donation or twin donation is evident or can be achieved. This relates to an isograft. Isograft is the terminology allowing survival of kidney transplants 10 to 20 years post-transplant, and quite well. That's suffice to say that there is a prognosis around isografts, around cadaveric and live donors that are not that don't fall in the category of isografts, that can also have a good prognosis. Okay, so that's some general introduction. Now I'm going to go into slide 3 now. So I mentioned a little bit about donors from where transplantation is concerned in relating to for example isografts, and a little bit about live and cadaveric. But a little bit of more emphasis here is that donors such as live from those who are living relatives, and also cadaveric recipients where they receive a transplant from a donor who has been pronounced as someone who's brainstem dead, have also been retrospectively appropriate, and of course basically as I'm sure to some extent listeners may know, that there has been literature published in various by various known authors relating to the fact that there has been in the past issues around the supply and demand aspect around organ donation and transplantation. And basically what this means is that the patients have to wait longer in some regard, and basically this is because the aspects that are related to the immunological parameters that are also linked with the major histocompatibility complex and the human leukocyte antigen characteristics are not going to be, and are less likely to be, or there's less probability for them to be identical, except again in live donors where there is a greater match complex, and again that relates to isografts, but those where the immunological components are less likely to cause or elicit a response that an attack a foreign organ. And we must know, we must understand that when a transplant is enters into the donor's physiological as part of their physiology, it will always be foreign. So that's something we must appreciate, and thus a decent match only occurs really because the scientific aspects that relate to the serological tests and investigations and the constituencies around that are similar, not identical, but they are similar. And then basically cadaveric transplants show greatest risk of rejection, but can be decent cross matches if carefully selected for post-transplantation. Now, apart from clinical scientists and biomedical scientists getting involved to actually do part of the test and investigation and the laboratory medical aspects that are needed and required, there are also clinicians who are going to be who are going to want to know how best to ensure patients can get the best out of their transplant prognosis. A sibling to sibling donor where HLA complement is similar should have seven. It can have 7 or more years prognosis. Now, generally in literature, on a generic basis, those who have live donors in literature retrospectively has highlighted that from live donors, the prognosis can be something in the region from 10 to 15 years or 15 years plus, rough as an estimate. And with cadaveric, it's between 8 and 10 years. And generally because when transplanted from a cadaveric donor to someone who's live, it's different because someone is being pronounced dead, or brainstem dead when being transplanted, or when an organ is being donated, versus a person who is his life at the time. So basically, the prognosis has some basis around that. Now, apart from this, in relating to the MHC and LHA characteristics between pediatric patients, the chance of a prolonged functioning kidney transplant survival thus reduces or is reduced based on the fact that the cross match and also aspects that can additionally be affected is where, for example, a pediatric patient could have their transplant from someone who's older, and that might not necessarily be ideal, although it's not a terrible disaster as long as all the other serological components are identical, are similar. Now, in relating further, rejection of transplants occurs mainly through what is known as cytotoxic T cell effects and immunosuppression, and the probable nephrotoxic side effects basically then can cause or are probable to cause challenges, because the T cells in detection of certain antigens and destination of renal and destruction of renal grafts or renal transplants, anti-helper cells aid in appropriate recognition of complexes. And basically what happens is that in a worst case scenario, for example, if for example let's say, for example, the immunological components are similar, but let's say from an HLA perspective, basically where on a panel test, where clinical scientists and some biomedical scientists might be involved, basically on a serological test, on a cross match test, basically out of the what's referred to as the lymphocytotoxic T cell test and a panel test, basically out of that where on donors on donors and where transplants are being matched, there's a six panel cross match test that has been implemented, and retrospectively, if there is even say, let's for example, three mismatches, and the other three, for example, match very well, then what can happen is that the patient, if transplanted, at that point, basically they could be placed on higher doses of anti-rejection treatment or immunosuppression, and that prompts more an illicit response in relating to not just nephrotoxic side effects from the immunosuppression, but also problems where basically in a kind of a roundabout way, what happens then is that the immune system and these certain cell types, the T cells, CD8 primarily, cause a destruction of the transplant. The immune system gets elicited a response to the extent that CD8 T helper cells, CD8 cytotoxic T cells cause a response to then prompt the transplant to reject, and that's obviously going to be devastating for patients, in patients as well as sort of people around them. And now, thus, ultimately, there will always be some form of risk or of having a form of transplant rejection. So now I'm going